So right now on the 2nd November 9th, on December 7th, we'll be Dr. Michael Lamantia, who's a geriatric specialist, who will be talking about addressing geriatric issues. In January, we'll be having Avoiding the Emergency Room with practical office strategies and nurse triage. Recordings will be available. We'll be sending out a link when those recordings are available for all of the classes and for all of the sessions. Please remember to mute your phones. We do get a lot of feedback on the system. Thank you. If you did request CME credits, the registration, evaluation, and post-test will be can you please? The post-test will be emailed to you within 24 hours along with a copy of the slides. You can complete those forms electronically, and then you can save them and send them to Laura Remick at Northeastern Vermont AHEC, and her email is available on the forms. So the Chittenden County Regional Clinical Performance Committee is a group that's been meeting for about almost 2 years now, and it's a team of cross-organizational members. And we've been working collaboratively to improve health outcomes in our region. The different organizations are represented on the Chittenden County RCPC, and as you can see, we have a kind of widespread organizational of different areas of healthcare that are represented. Focusing on ED utilization, as we looked at the data on areas that we're hoping to improve in our region, and we've saw that the ED visits per 1,000 members, this is Blueprint data, has continued to go up over the past couple of years. And data in 2015, there were 1,258 visits for 4 common conditions, including nausea, vomiting, diarrhea, cough, URI, and UTI. And a significant number of those patients were pediatric patients that include non-English speaking new Americans. Our goal for the ED utilization work group is to reduce the incidence of unnecessary emergency visits by 5% in 2017. We want to duplicate current ongoing projects, and there are many that are looking at decreasing ED visits, including the Chronic Care Collaborative that is looking at chronic disease, and there's a group looking at mental health issues, and there are efforts with the ENA look at connecting people with health services. So we found that this area of having non-emergent visits to the ED was an area that we felt that was a gap, and we have chosen to use these webinars to just share some strategies and best practices for office treatment of these different conditions. So with introduction, I'd like to introduce Dr. Andrea Green, who's from the UVM Department of Pediatrics.
Hi, thank you very much, everybody. Moving slide forward, I'm going to be your first speaker, and neither Leah nor I have any disclosures. If you can move the slide forward, please. Thank you. And our objectives, moving the slide forward, are first, understand the use of the emergency department by children and families for minor illnesses. I'm really going to talk a lot about health literacy and some unique circumstances. And then Leah's going to outline some strategies to support families, to encourage acute primary care, and to mitigate the inappropriate use of the emergency department. Slide, please. So the scope of the problem in looking at it is overuse of the emergency department represents about the fourth largest category of waste in healthcare. And it's been estimated through a study looking at reducing emergency department overuse in Massachusetts in 2010 that about 56% of all emergency department visits have been avoided. Next slide. The reasons that the emergency department is overused are, number one, issues related to access to primary care services. Number two, issues related to after hours and weekend care services. Three, people's anxiety levels, and I think that it's really important to acknowledge that a lot of families have a lot of anxiety, especially when you can look up symptoms and be really alarmed by what you find on the internet or what you're seeing on Dr. Oz. 4 and 5 really have to do, Leah will talk about primary care referrals to the emergency department, and then it will be addressed elsewhere to talk about the financial and legal obligations to treat patients. But what I'm going to focus on is number one, and I'm going to talk about access issues. Next slide, please. So there is access, as we all know, and I think living in a rural state, we're very sensitive to the fact that transportation can be a major barrier. Often people in our office will not be able to make a visit time because they don't have a ride, can't get there, and sometimes, therefore, they need to be seen outside of primary care hours. We have less issues around insurance in the state in that most children in the state are able to be insured, but if you are uninsured, you're much more likely to use the emergency department because you will have a primary care provider, and so that can be an issue. Our family factors related around work schedules, children nap time, pickup times from school, different activities that kids are doing, having to get to the bus, the issue of parental depression and anxiety that can make it difficult for people to take appointments. I'm going to focus on today is the concept of health literacy. Slide, please. So literacy is an important issue in health today, especially as patients are taking a greater role in obtaining information about their health. And literacy is commonly defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. But it's really a pretty broad term that's used to describe the ability of people to get health information, to understand it, and to use it to make better decisions concerning their health. General literacy is obviously important because it's the foundation for health literacy, but health literacy requires more than just the ability to read an informational brochure. It's really also the ability to discern whether or not that information is reputable, to manage that information in a beneficial way, and how to use it to make health decisions. Next slide. So why does health literacy matter? So it matters because nearly 1/2 of all adults, or about 90 million people in the United States, have a hard time understanding and acting on health information. And studies suggest that health literacy can be a stronger predictor of health than even race, ethnicity, income, employment, or education level. I included a link to a video, which I'm not going to show because we don't have enough time, but I highly recommend it. It gives some real-time examples of physicians talking to patients and patients understanding what's going on. There is one man who is, he has high blood pressure but does not understand he has hypertension and thinks hypertension means he's hyper. And there's another woman who talks about consent for surgery and not realizing until a month later that she'd had her uterus removed. So they're pretty powerful examples, and I definitely encourage you to watch that to get a sense of how important this is. Next slide, please. So the average reading level in the United States is 8th grade. And 75 million, or 1/3 of adults who studied in a 2003 study that was used for the Institute of Medicine report that came out in 2004, found that those 75 million American adults, or 1/3 of those studied, had an English literacy rate that was basic or below basic. And that means that they could understand a simple patient education handout if they had basic understanding, or they could circle a date on an appointment slip, but that's what they could do. Next, please. So if you have lower health literacy, you tend to be someone who has not received education beyond high school in general, that you may have disabilities or activity restrictions related to health issues. You may be part of a minority population or be immigrants, the people I take care of, or you can be people with one or more chronic disease, and often people on Medicare or Medicaid. Next slide. But important to note that even people who have post-secondary education, people who have completed high school and have gone on to get other education, may have good vocabulary. Only a third of those people who have a higher level education degree have health literacy proficiency. Proficiency is described as the ability to define a medical term from a complex document and to calculate a share of an employee's health insurance cost. I think it's really important to recognize that even people who have a lot of vocabularies or a lot of education may have difficulty understanding health information. Next. So literacy means that informed consent is not well informed, and that's a real challenge for us because often our consent forms are very difficult to understand, and usually we sign them without reading them even ourselves. Medication instructions and compliance can be very difficult if you cannot read the prescription. And I should just make an aside that there's some good work going on here looking for ways to help solve that problem through our pharmacy system and with our interpretive services. And if you have poor health literacy, you're less likely to have preventative and other routine care because you have access issues, because of trouble understanding when you have an appointment, making appointments, and so forth. Next slide. Is a slide from Australia that just talks about why health literacy is important, and why I wanted to put this up is really not so much to show all the different ways that it can affect someone, but because it comes out from safety and quality. And I think that's really important. I think one of the things we recognize is that we need to focus on literacy in healthcare because it really affects safety and quality. Next. This slide is just to show sort of the myriad of ways that one needs to have the ability to navigate a system or to have health literacy. So obviously, if you're looking for a provider, you need to figure out how to find somebody. Then to find somebody, you need to figure out how to navigate the phone line and what that means so that you can even schedule an appointment. Then you have to figure out how to get to that appointment. Once you get to that appointment, you have to go to registration, and you have to figure out how to navigate that entire visit. Next slide. When you think about a visit, it's not only just a pre-visit scheduling an appointment, it's get to the office, having your records, filling out the forms that give you, to give people what the names are of your illnesses, the names of the medications that you're taking, to being able to give a past history, to be able to understand the instructions that are given to you in the clinical visit, to being able to understand the teaching that's given to you, to being able to navigate getting to the pharmacy or to the lab or to wherever else you need to go, and then to be able to comply with the instructions and schedule that follow-up. So it's a real continuum of confusion that can happen, and I think often because of this, so many challenges in the system, people sometimes just end up in the emergency room. Next, please. Because that outcomes of poor health literacy are overuse of the emergency room, but also increased mortality, lower satisfaction with care, lower quality care, worse patient safety, and higher healthcare costs. Slide. So I'm going to talk a little bit about taking that further with cultural history. So I talk about the immigrants because that's who I work for, but I think we have to remember, as I've already stated, that there are a lot of health literacy issues that people have even if they have good English and good vocabulary. So cultural literacy is another piece of literacy where it's not just even about language and language differences or language challenges. It's really about religion, culture, beliefs, and ethnic customs and how they influence health concepts and how people take care of their health. And just a reminder that we all, I know, try to practice cultural humility and to sensitive cultural difference. So what I'm hoping to do in the next few minutes that are assigned to me was to just run through some of the things that I've learned about with my immigrant population that have helped see things from a new point of view. Slide. So this is a slide that just shows refugee arrivals in Vermont since 2004. Usually we have upwards of about 400 new refugees who come into Chittenden County. We'll be having refugees coming into Rutland County starting in January. And you'll see that who comes can be very varied. Since 2008, the majority of refugees who have been resettled have been from Bhutan, and they speak Nepali. And within each of these refugee communities, we have people with varying levels of health literacy. Some people have education, some people do not have education. But an awful lot of them have interacted in the healthcare system without being educated about the healthcare system they're interacting within. Next slide. And when you think about refugees and where they're coming from, which for us mainly sub-Saharan Africa, the Middle East, and Asia, and you look at the under 5 mortality rate, 2015 put out by the World Health Organization, you will notice that the colors of the things that light up orange, either light orange or dark orange, match the countries from where our refugees are coming. Please. So considering why there may be overuse of the emergency department by the refugee population, I think it's important to consider the fact that they're coming from countries with high rates of child mortality, and that many of the refugee communities that we are seeing have experienced death of one or more of their own children. It's important to acknowledge that pneumonia and diarrhea are the #1 causes of death in children worldwide, and whereas we think of them as more minor illnesses, we don't think that they carry the same risk for an awful lot of families. When you ask what was the cause of death of one of their children, it will be things like pneumonia, or it will be hydration and diarrhea. Families we see are familiar with oral rehydration salts, but they are familiar with things like Pedialyte or Enfalite. They are unable to access those in a way that helps them. Also, when they do go in or get treatment, they're often told to hydrate with things like popsicles. Many families we take care of have ideas around hot and cold in treatment or other cultural ideas around treatment, and popsicles would be considered inappropriate for treatment of diarrhea because they feel that things need to be hot. In a sense, if you're coming from a country where your water source may be contaminated or unsafe, you would boil that water before you gave it to anyone who is in an immunocompromised state. So often I explain to families that we will recommend things that are cold here because we don't worry about parasites. We don't worry about contamination of our water sources, and so it's not something that we're sensitive to. Acknowledging that with families are often much more receptive to considering all the different things that we're talking about. Many of our families, especially those coming from sub-Saharan Africa, have been taught to seek care at first sign of fever with their children because of the risk of malaria. And we do have mosquitoes here in the United States, but our mosquitoes do not carry malaria, or for people coming from Japanese encephalitis. So we see some risks in our mosquitoes, but not the same risks that patients do. If you've come from somewhere where your child might die rapidly of malaria, or you have that concern or have been taught through the clinic sim in the refugee camp, you'll be much more quick to go immediately for fever and not wait for an appointment in the office the next day. Rashes, often people will go in less likely to the emergency room for this, but again, measles is the 4th leading cause of mortality in the world, so people may have a lower threshold for concern around rashes. When we talked about family factors for overusing the emergency room, I think it's especially important to recognize the trauma that a refugee population has experienced. So these parents have heightened anxiety, and especially when it comes to their children, because they've witnessed and experienced an incredible amount of things. Next slide. Working with people who are non-English speaking, there's a law that one must use an interpreter. Interpreters can be via phone, iPad, or in person. And interpreters have the latitude to act as patient navigators to help with access, which can be really helpful in working through the system. They also can move out of their role as interpreters and can give you some cultural tips if you will invite them to do that, and that can be helpful in understanding some of the cultural differences in attitudes. I always consider interpreters as part of the medical team, and we want to remember in working with them that we want to avoid jargon, idioms, or abbreviations, especially in pediatrics where we use a lot of these, and to make sure we're using plain English in sentences. We also to remember that even people who can speak English, when they are feeling vulnerable or sick, have less access to that second language. And so even if they do have some English, it's important to offer them an interpreter or to an interpreter to make sure that that they can communicate properly since they may be in a vulnerable position. Interpreters are billable, which I think is important to mention in the state of Vermont. We can bill for them. If you're in the UVM system, we do that through charge capture, but the billing code, if you're outside the UVM system, would be T1013, so I put that there. And just a reminder to never use a family member as an interpreter, because that puts them in an uncomfortable place where it's very difficult for them to be accurate. So please use interpreters either through the phone, iPad, or in person. Next slide. I wanted to mention a couple tips for making sure that people understand. And the first is called the teach back method. This is quite self-explanatory, and I think we all try to do this, but this is where you explain what your recommendation is, ask the patient whether they understand what that recommendation is by asking them to repeat it back in their own words. And then you can clarify that they've fully understood, and if they haven't fully understood, you can work to make sure that whatever that point of misunderstanding is has been corrected. Next slide. The tool that you can use is called Me3 or Teach to the Goal. It was designed by the National Patient Foundation, and it encouraged patients to know 3 things before leaving a visit. First, my main problem. Second, what do I need to do? And why is it important to do this? Next slide. And Leah is going to go into this much further, so I will just briefly mention that we work very hard, at least in our office, to prescribe acetaminophen, ibuprofen, and rehydration solutions, because often people are coming in, they haven't got the ability to pay for these things, and one of the things they're looking for is a prescription for them. So if you provide those before, often then they don't have to come in. We also work in our office to address social barriers of health, and those barriers, to acknowledge the issues that people have. And one of the things that can be helpful is when you're calling for follow-up for someone who did go to the emergency room, is to ask them why they went and to see if any of those barriers are there, and you can see about figuring out ways to solve them. In the office, to use these low literacy tools like Teach Back, Ask Me3, and the BEG review, which is basically having patients bring in their medications and going through them with them so they can make sure they understand how to take them. There is going to be a number coming for the University of Vermont Medical Center that's a single access number that you are going to be able to call in as someone who's non-English speaking and be able to be connected to someone who's on call or to an office with an interpreter just by calling one number. So that can be really helpful. And it's going to talk about this, so I'm going to pass it over to Leah. Thank you very much.
Andrea, hi, this is Leah Costello of Timberlane Pediatrics in South Burlington. I was just going to talk about some office-based interventions and then give some triage advice for a few of those categories that Tanya talked about earlier that we're trying to, the illnesses that we're trying to reduce ER visits for. So some simple office-based interventions. There's many things that we can do to reduce our ER visits, but signs, handouts, making sure that we are providing consistent and accurate information about medications, empowering parents to treat their children at home, and that our staff is also offering consistent and, again, accurate triage information as well. Next slide, please. Slide, please. Oh, perfect. Thanks. So you would be amazed about how many people do not know that you are available after hours for phone calls. If you do just a simple survey within your office, or even if you just are following up on an ER visit, it's often, oh, I didn't know we could call you. So some signage in your office or message on your voicemail could help just remind people to call you first before heading in. Make sure that you mention both your hours and your on-call service to all new patients, and even mention it for the first few checkups, just so that you know that families are hearing this. It's shocking to how many people don't know this about your office. Next slide. I also like to provide information about UVM's urgent care. I'm really not familiar with any of the other ones in town, but this one does seem to, for minor issues, does seem to do well with treating pediatric patients. As you know, they're staffed by family of practice physicians and advanced practice providers. They can place IVs and provide IV fluids for older kids who have mild dehydration, suture and glue wounds, and kids who don't need to be sedated for the procedure. And then they have the X-ray and splinting availabilities for kids who don't need ER-based surgical interventions, and certainly a great option for kids that you don't think need to be seen by the pediatric service at the hospital. Next slide. office-based interventions you can do are always either providing dosing tables for ibuprofen and Tylenol, providing the doses in an after-visit summary, or one office. When I was kind of gathering information about office-based strategies, I spoke to several pediatricians in town and asked what they do in their office, and one has dosing signs in their exams rooms and says, take a photo of this so parents can have it and take it home with them. Reminding patients, obviously, no Tylenol before 2 months and no ibuprofen before 6 months. Just as a side note, regarding alternating medications, alternating Tylenol and ibuprofen, I don't personally recommend this as there's a lot of risk for accidental overdose. I will often tell families to pick one and stick to it and then make sure that the child is appropriately dosed. But that being said, if someone calls me at night and wants to avoid an ER visit, I will have them, and they're consistently giving Tylenol, but the child is still febrile, I will have them give a dose of ibuprofen, even if they have just given Tylenol, to see how we're doing. If families want to alternate, I really warn them about the risks of overdose and good use of, I just say to take a sticky note and put it on the bottle and write the time that you gave it last. And then, as Dr. Green mentioned, really providing prescriptions for these ibuprofen and Tylenol for Medicaid families so that you know that they have it in their house, that they're not going to the ER just because they don't have that medicine. And again, that truly does happen. Next slide. Oh, this is an ibuprofen. So the previous one was Tylenol dosing. This is the ibuprofen dosing. And then I put this up just to remind you that there is actually a difference between infant Tylenol and infant ibuprofen and children's ibuprofen. So the infant ibuprofen is 50 milligrams for 1.25 mLs, and children's is 100 milligrams per 5 mLs. There's no difference in Tylenol. So the infant and children's Tylenol is exactly the same. It just, the infant comes with a syringe, but just when you're giving parents advice over the phone, find out which one they have. And then we do not recommend any cold medications for children under 6 or any products with multiple medications in them. And again, for kids 6 for sure, but older that they often don't work anyway, so it's not part of our current regulations. Next slide. Yeah, it's also helped to keep, because obviously what one's here in the office and what they remember at home can be different, especially if their child's running around and opening every cupboard drawer and things like that. So providing after visit summaries, the dosing charts, providing handouts about resources. We'll talk about healthychildren.org in just a minute, and then providing consistent handouts on home-based remedies for colds and flus, vomiting, diarrheas, simple things that parents do. The AAP through healthychildren.org has great handouts. Up to Date actually has quite reasonable handouts, and then sometimes through larger healthcare networks such as Intermountain Healthcare or Children's Hospital of Philadelphia, you can find really good parent handouts on common viral illnesses. You could even kind of take those and create your own with your own phone number and office hours so that you're sending parents home with something. Especially helpful if it's a family where you see the kid with the mom in the morning and then they're going to go stay at dad or grandparents that night, so that they also have that same information from you. Next. To empower parents to help treat kids at home. So at Well Child Checks, we make sure they have the Tylenol, the ibuprofen, Benadryl when starting table foods. I provide a recipe for saline drops for when a kid has a cold. I talk about having a humidifier at home. And these are also just things that I talk about at Well Child Checks so that they're prepared should the kid get sick, especially like right before entering daycare for a baby or between that 6 months to 12 month visit when they're starting to move around a lot more, put things in their mouth, they're just more susceptible to illnesses at that point. And then really we want to avoid fever phobia. We'll talk about that in a few minutes, but I think we can really play a big role in that. So next slide. The healthychildren.org is a fantastic resource for parents and has really improved greatly over the last several years. I write this on the board when I go in and see a newborn at the hospital. I remind parents at Well Child Checks. It's our website, and it does, saying go to the website increases our website traffic too, which is good for us. Next slide. At the above the healthychildren.org page, you'll find a symptom checker. It's the one where they're putting the thermometer in the child's ear. There's also an app for the kid's phone. Next slide. Click on Symptom Checker. You then hover over the area of the body that the kid is experiencing symptoms for. I actually even recommend this site to residents for when they're getting triage advice on the phone at night. Like if they could just look here too for great advice. But so if you hover over abdomen, next slide, then you can pick from a drop-down list of what's going on. And if you select in abdominal pain female, you get to the next page. Next slide, please. Has excellent information. You can see the definition of abdominal pain, when to call, care advice, and then I'm not sure actually what they put infos in this, but call your doctor now, go to the ER, and the next slide will show you they have a very long list of things that you can try at home, and this all just covers just abdominal pain in females. So it's really good, clear advice for parents, and especially those with a lot of anxiety, and it's through the American Academy of Pediatrics, and so I do like the resource a lot. The next slide, please. Agoraphobia, and I really think we perpetuate this as medical providers, and this is where I was a little bit stressing at the beginning, consistent advice from our triage nurses and from us. I have conversations about fever so much when I'm on call that my husband can honestly recite my speech, and actually when our daycare called last week about my daughter's temp of 99.4, he did a great job. So just a note, the child is less than 3 months of age and has a fever 100.4 or greater, they do need to be seen. Obvious exceptions to this if they've had their immunizations in the past 24 hours and are well appearing. Or if I have seen a kid who is 2 to 3 months of age, they had a cold, things had a cold, they're in daycare, really obvious URI symptoms, and they're feeding well and acting well, and they have a low-grade fever, I'd have that child seen. But you are never wrong to send them in. That is certainly who you could mean, but I would agree with you that if they had a cold and a fever and were feeding well, well hydrated, that they could stay home and be seen the next day. So a fever after 3 months of age, a child with a normal immune system and is up to date on immunizations is 101. I personally just like the digital thermometers for home use. They're cheap. The rectal for the kids under 3 months and oral, or even axillary for kids over 3 months. The ear thermometers are really just not as good, and kids under 6 months, you can't get a good feel with them. So when I talk to families about fevers, I always preface it with it's not the fever itself that's dangerous. It's that fever in kids under 3 months can be a sign of a more serious illness, and this is why they need to be seen. When I talk to older families about families with older kids about fevers, I talk about it's not the number that we worry about, it's how the child is acting, and specifically how the child is acting when we bring the fever down, because nobody feels good with a fever. So that's why sometimes I will say, okay, you've been Tylenol an hour ago, let's give another dose of Ibuprofen, see how, and then call me back in 45 minutes or an hour, and let's see how they're acting then. Even if we can bring it down a little bit, it can improve their behavior, their ability, their appetite, and if they are then either bouncing off the wall or just actually acting a lot more active and hungry, then we can rule out a lot of illnesses that way, specifically like meningitis or pneumonias or appendicitis, just based on how they act when we bring the fever down some. I know of pediatric offices that actually don't even check temperatures at 6 visits in kids over 3 months of age, that we're not teaching parents with every 6 visit that we're concerned about that number, that the doctor wants to see how the kid looks clinically, not what that specific number is. And for treating a fever, I also talk about that when I talk about just sick management, and I'm giving my anticipatory guidance about illnesses, is that we treat the fever if the parent thinks the child would be more comfortable and improve their oral intake. We do not treat just because it's the number of the fever. So if a kid is running around and has a fever of 103, let be. Go into just a little bit more. The next slide. The healthychildren.org website has an excellent review of when to call with fevers, and I think is very very clear. You can see looks ill when is unusually drowsy or is very fussy, has been in a very hot place, such as an overheated car, has other symptoms like a stiff neck, severe headache, severe sore throat, severe ear pain, unexplained rash, or repeated vomiting or diarrhea. I think they just use very good terminology in that. In emphasizing severe and repeated. Obviously, if a kid has, we're talking healthy kids here, if there's an immune system problem, that's a very different, that's a different talk. If the child has a seizure, and then if the kid is under 3 months. So I do really like this page here for when to call the pediatrician about fevers. If parents are still looking at me with a funny face, like I don't know what I'm talking about dangerous fevers, I talk to them about how fevers that are dangerous are environmental. A kid left in a hot car, or a kid who has hypothalamic injury and cannot, like a brain injury, and cannot control their body temperatures. High fevers alone do not cause seizures. They are certainly a risk factor for them, but they do not cause them. We actually do not know specifically what causes febrile seizures. There is a genetic component and an age-dependent component as well. But the most common identified risk factors of seizures are an underlying genetic susceptibility, a fever over 104, viral infection, recent immunizations, and a family history. But we don't give medicines to prevent seizures. That is, febrile seizures are really a benign and again, for another discussion. But there is no number of fever that I feel like needs to be seen immediately for fever associated with an illness. A environmental fever is different. We recommend bringing down the fever with appropriate doses of medicine and see how the child is acting and then decide. We can obviously give the advice to dose ibuprofen even if the child has just had acetaminophen or vice versa. And we can recommend keeping the kid comfortable, but do not place them in a cold bath unless it's an environmental high temperature. And then I think one strategy that really I heard across all pediatric offices is try this and call us back in 45 to 60 minutes so that the parent knows that you are available for another phone call. I know that could mean another phone call in the middle of the night, but it does really reassure the parents that you are worried about them, you want to hear from them in just a little bit, and that you are supporting them. I think this phobia is also perpetuated by our staff, that if they're alarmed by fevers, then the parents are going to be alarmed by fevers too. So we need to help our staff understand when and when to be concerned. And then one last thing about fevers, if a kid isn't immunized, this all also goes out the door. I'd be more concerned about Haemophilus influenza and strep pneuma, and probably more likely to refer for evaluation. So I do always ask about immunization status. I think it also just puts the bug in their ear that we are thinking about it all the time too. So this fits into a little bit more triage advice for some of these other illnesses. Next slide for me, please. So the BartonSmit book is the most commonly used pediatric telephone protocols book. I assume most of your offices have it. It's great, consistent, clear advice for your nurses and for yourself too, if you feel unsure about advice for pediatric patients as well. And this is available through the ap.org web store. Next for me. Thank you. So for upper respiratory tract infections, obviously parents worry about their kids, and we need to provide a lot of reassurance around colds, reassurance that fevers can occur with colds, that this is normal. Especially in babies and young kids, colds can keep parents and babies, keep the patient and the parents up most of the night. Babies and kids who can't clear their nose or cough very effectively get these mucus plugs and will suddenly act sicker, particularly in the middle of the night. But I always will say, bring them into a steamy bathroom, blast the humidifier, use the saline drops, the recipe that I mentioned earlier, 1/4 of a teaspoon of salt in 1 cup of warm water and a few drops in each nostril. If they return to eating well and can feed after that, they do not need to be seen. It was just a little bit of mucus plugging that caused some distress. Families also need to know that colds will get worse often for 3 to 5 days and before starting to improve, and that the cough and congestion can last 10 to 14 days even in kids. I think if they know that this might happen, they it's they expected and not be running into the ER as quickly. Regarding croup, barky cough with stridor does need to be seen in the ER, with the exception that if a kid is over 2, and the family brings them outside, a stridor resolves immediately, they return to normal breathing, I may not send that child into the ER. But barky cough alone does not need to go in. That can be treated with cold air and steamy bathrooms. It's barky cough with stridor, and just demonstrating stridor or and croup is great because you can just put that up to the phone and you can hear stridor, that whistling noise when they breathe in, the noise. You don't have to actually hear over the phone. Always having an asthma action plan for your kids with asthma printed out for every household that they're going to be in, demonstrating very good use of spacers and medications, reviewing asthma action plans. Those are things that can also help to have that kid, to empower parents to treat their kids at home as well. Next slide for me. Here's the saline drop recipe. I forgot I had it on the next slide. So the home remedies for URIs that we spoke to a bit earlier, fires, steamy bathrooms, honey for kids over 1, saline drops, and then encouraging slow fluids. And again, no cough medicines for kids under 6 years of age. Ear pain, next slide please, associated with UIs, that this is not an emergency. 1 dose of antibiotics at night in the ER will not change the course of an ear infection that immediately. I just try to convince people it's better to get ear pain under control and a good night's sleep and be seen in the morning to start antibiotics. Even a draining ear does not need to be seen immediately, obvious exception of head injuries with clear fluid coming from the ear. That's different. But one thing regarding ear pain that would need to be seen more immediately is if you're concerned about mastoiditis, which usually presents redness and tenderness behind the ear, and then the ear itself being pushed out, so kind of cup-shaped of the pinna of the ear. Never put anything in the ear, and a warm washcloth can be used for ear pain, but the topical anesthetics like Aralgan or benzocaine are not, the FDA is no longer recommending those as of about a year ago. Slide. Throats with URIs that need to go to the ER for a very stiff neck, excessive drooling, like cannot swallow their drool, tripod positioning, inspiratory stridor, and then signs of moderate or severe dehydration. The strep, unless they have these symptoms, is never an emergency. And there's actually a new study that was just last year of the Pediatric Journal of Infectious Disease that kids may only need 1 dose of antibiotics before returning to school. So they could be seen in the morning and still return to school the next day. This is not an official AAP recommendation yet, but there are some more. It probably will be soon. So for the slide, so regarding gastroenteritis and abdominal pain, going to ER if they have bloody or bilious emesis, to appendicitis. If a kid cannot jump, that is, often have the families ask the kid to jump. If they cannot do that, then they may need to be going. But if they can jump, very unlikely they have appendicitis. And then the moderate to severe dehydration. No tears, no wet diapers in the past 6 hours for under 1, and I even say kind of 8 to 10 hours in a kid over 1, sunken eyes, dry mouth, and then repeated bloody stools or bloody stools with pain and fever need to go in immediately. But really I do try for mild dehydration or as an initial step trying the or rehydration at home. I'll go over that in just a minute. Regarding bloody stools, in an infant, particularly in that 4 to 8 week age range, they can have allergies or fissures. If they have bloody flecks in the stool with a mucousy stool and they're acting well, eating well, comfortable, and do not have a fever, those can be seen the next day in your office. Obviously, if they're febrile, poor feeding, uncomfortable, they should be seen, and we would never, we'd always be happy to see them in the middle of the night for that. But acting well is just flecks of blood. They may it's probably likely to be a milk protein allergy or a fissure and could be seen the next day. So home remedies for gastroenteritis is on the next slide. That's about the last slide. The recommendations for oral rehydration solutions. So in kids over 6 months, an article, JAMA article in 2016 showed that they actually do better with half-strength apple juice. I don't know how many of you have tried Pedialyte. It's quite sweet and thick and just kind of gross. But Pedialyte popsicles are actually better tolerated too. But you can do half-strength apple juice for kids over 6 months. Kids under 6 months, I recommend Pedialyte, or actually even just breast milk is fine. You're going to want to do 50 to 100 milligrams per kilogram over 4 hours. For an average 1 to 1.5 year old who weighs about 10 kilos or 20 pounds, you'll try to give at least 4 ounces an hour, so 1 ounce every 15 minutes, or 5 to 10 mLs every 5 to 10 minutes. There's also studies showing that, and this is the Journal of Pediatrics, that a single dose of Zofran, and we use 2 milligrams for kids less than 20 kilos and 4 milligrams for kids over 20 kilos, that really does help oral rehydration therapy work as well. But if you're needing more than 2 doses of Zofran, you need to reconsider the diagnosis. It might be viral gastroenteritis, and it's okay to redose Zofran if they vomit immediately after it. And then again, always okay to continue breastfeeding. So my page is just kind of wrapping up. But some final thoughts for you. We do always call our patients who go to the ER the next day to see if they, one, obviously, do they need another visit, but do they view our hours, our on-call service, and see if there were barriers to care, and those are part of our triage, like our nurses who make these follow-up phone calls that they ask these things. We obviously cannot change everybody's behavior. Some people need to just go to the ER, and that's okay. Parents really worry about their children, but the more that we can talk about this in well checks, I think, helps them really empower them to take care of their kids at home. And then mentioned earlier, I always find that telling a family we'll call them back in 30 to 60 minutes, or to have them call me back, just helps with reassurance and that they know that they're not alone doing this alone. So that is the end of my presentation.
Hey, thank you very much. That was excellent information. If anyone has a question, I'm going to unmute. I had muted a couple of people. If you have a question, if you can unmute yourself, ask your question, and then mute yourself again. Any questions for Leah or Andrea? It sounds like we don't have any questions. In that case, thank you everyone for attending. Those of you who requested CME, I will be sending out the forms, and we'll be sending out the slides, a copy of the slides to everyone, all the participants. And do stay tuned for a recording that should be available in the next few weeks for a review. So if there are no more questions, thank you very much for participating.
Thank you.
Thank you, and Leah. Those were excellent. Thank you.
Thanks much. Bye, guys. Have a nice day.
All right.
Bye.
Take care. Bye.